because some of the hospitals had questions about billing primary bills as well as modifiers, given the amount of time spent with each patient, especially here at Emory Johns Creek. So this is my favorites list under my billing. So I just came over here to my charges, and then these are all the bills that I have as a favorited bill. What I'm going to go through during this short video is primarily going to be billing for level, which is the level 3, which is what our objective is to bill at, how to use your medical decision making or MDM to bill level 3 or to bill based on time. I actually think that we should bill for both, but we should start shifting towards more towards time, mainly because here at Emory Johns Creek, I've noticed in my very short tenure here rounding on the floors that we spend a lot of time with our patients here. And I think billing for time will be more productive from an RVU standpoint and a variable comp standpoint. So the ones that I'm going to talk about today will be the 99291, which is critical care billing, 30 to 74 minutes. I'm also going to discuss your inpatient subsequent progress note level 3, which is 99233, as well as your level 3 admission bill, which is an inpatient admission level 3 bill, which is 99223. And it is important that you'll have to eventually remember these numbers, the 99223, but that will be easier once I go through the sequence of how we bill them. On any given day, the primary bill should either be the critical care billing 99291 or a discharge 99239 or an inpatient progress note a 99233 or an admission H&P note bill, which is a 99223. So let's start with how do you determine the billing level? And these are slides that were given to me by Gina Evans, which I will credit her at the end of the presentation. But essentially, how do you determine the billing level? So there's two ways that you can bill on notes in general. There's billing on time, and there's also billing on elements of medical decision making. I think here at Johns Creek, we should start billing on time. You're also going to end up doing both. Typically, when you bill on time, you end up still having medical decision making in your note. But discharge summaries have to have a time component on them. Without a time component, they cannot be billed for over 30 minutes, as well as critical care notes have to have time component in them before they're valid. So I think because a lot of the notes already require time, it would make sense that all of our notes now have time in them. So if your medical decision making does not cover the necessary requirements to bill at level 3, you can fall back on your time, which can still qualify. So there are 4 levels for medical decision making. The straightforward I'm unclear on, but I know there's low, moderate, high, and we're going to primarily go through high because that's where majority of your bill should be if you're documenting properly and you're documenting how much time you're spending on the patients, which a lot of times even if the patient is not critically ill in the hospital, if we are spending a lot of time going through the charts, discussing with family, getting everyone up to speed, talking to consultants, pre-rounding, we do spend a lot of time on these patients, which makes the time component of billing make more sense. So let's move on to the high medical decision making. So this is based on medical decision making that's required to bill a level 3, and that is a 99233 for a progress note. This 99223 is for an inpatient H&P. The 99236, I believe, is for a consult note. The 99236 is for an admission discharge on same day, and the 99255 is a consult, but I'll go through those separately. This is what you need to bill a level 3 progress note or H&P just based on MDM medical decision making, not billing based on time. And I'll let you go through this just for the sake of keeping this pretty short. There's a lot of stuff that you have to keep in here, and there's a lot of stuff that you have to document in order to qualify for a level 3 bill. Whereas if you're going to bill based on time, these are the guidelines that are based on time. A lot of them are preparing to see the patient, reviewing the labs and radiology tests. That's something that we do every day when we pre-round. Obtaining and reviewing separately obtained history. That could also be talking to the patient, getting history, or using the chart to go back, using Care Everywhere to pull documents. All of this adds up to the amount of time that you're spending on the patient. You are also going to see the patient, discuss with the patient, discuss it with the family, potentially have to discuss with other family members, counseling and education for the patient and family. Like all of these are included in the time it takes for you to see this patient, discussing with consultants, documenting clinical information, and then care coordination. So this is actually pretty simple, and I'll help you with a phrase that you can add at the end that's saying, in general, what you're doing for this patient that qualifies you spending this much time. And I'll go over exactly how much time needs to be spent with each patient based on what level. And this is going to be a little bit more finite than the MDM, which I thought was a little bit more subjective. So this is just for the completeness sake of the video, I just have this in here just so you can pause the video and look specifically again at what you need for MDM. For each level. What I really wanted to show you though is if we are going to bill based on time, this card also has the time requirement. So if we look at a 99233, which is right here, which is an inpatient HMP, you have to spend a minimum of 70. If you spend a minimum of 75 minutes with this patient, that automatically qualifies as a level 3. If you're spending 75 minutes doing all the things that were listed under the time guidelines, that's level 3. And you really don't have to get into the weeds about the MDM if you're spending that much time doing the qualified things that amount to 75 minutes. If you're doing a 99233, which is just a progress note, it's 50 to 64 minutes. If you're spending 50 minutes going through why the patient's here, what we're doing for them, making medicine changes, going over them in rounds, talking to the family, going back and speaking to consultants, going back and reviewing lab work. I can almost guarantee for a lot of your patients, you're spending more than 50 minutes in totality, which qualifies for level 3. And then this is also going to be important. When you're doing time, modifiers to your primary bill are going to be very important because most of them are time dependent. So prolonged services. This is going to be one of those modifiers. So what prolonged services is essentially if you're going to spend more time than the allotted time required. So let's say for a 99233, which is a progress note, a subsequent progress note for a patient here, if you spend over 64 minutes, like let's say each of these 99418 is an extra 15 minutes of total time on top of these level 3 bills. And by the way, they have to be level 3, either a level 3 HMP or a level 3 progress note in order for you to tack on an extra 15 minute of prolonged services. And I'll go exactly what's required for this, but essentially, if you have a level 3 progress note and you spend 65 minutes with that patient, which is why it's 50 to 64, if you spend 65 minutes coordinating care and doing all those things that we discussed in the time guidelines, then not only are you going to bill a 99233 inpatient subsequent progress note, you're also going to bill on top of that a 99418. What that's going to look like is if I have a level 3 and I bill level 3, and let's say usually when I bill, I add these problems, and I will go in and I'll put my problems here, and then this will be a level 3 progress note. But when I accept that, if I also spent an extra 15 minutes with that patient, I will also put a prolonged services 99418. So I'll also put that in there. And during my prolonged services, I could have potentially just discussed the same thing. So I'll put that in there. And now you have your inpatient progress note level 3, which is a 99233, plus an extra 15 minutes, which is a 99418. And in your note, when you do have a note, it's important when you're doing, progress note. This is not going to work for me. So at the bottom of my progress note, so here's my progress note, and at the very bottom, I spent the total time of 55 minutes, and then I wrote this time component over here. And even though when I do fill out my progress note, I do have a lot of MDM that's in there, I still have this component at the bottom just saying what I was doing: preparing to see the patient, obtaining history, performing appropriate examinations or evaluation, counseling, family, reviewing imaging. So it's a very generic thing, just saying what exactly it is I'm doing. And the reason why I can do this is because I do this every day. I kind of do the same thing. I mean, you're reviewing your patients, looking at labs, looking at images. You're doing this every day on the patients. So I just put it in here. And if I just spent 55 minutes on this patient, that would then qualify as a level 3. But let's say I actually did spend 65 minutes with this patient. I would update my total time to 65 minutes, which would then fall in line with this bill, which is going to be inpatient progress level 3, which goes up to 50 minutes, plus an extra 15 minutes, which makes it 65 minutes. My documentation now matches my bill. And then I can hit, sorry, let me get rid of these. I was doing this earlier. And then I can say that this is what I'm doing, and then I can accept those charges. So that's how you add the prolonged services. If I spent more time, let's say like I didn't just spend 50 minutes plus an extra 15 minutes, making 65 minutes. Let's say I spent an extra 30 minutes with that patient. So I actually spent 80 minutes with this patient during the progress note. And a lot of that is maybe in the beginning I spent 65 minutes, but then I had to go back and I had to speak to another family member came and they said, well, I don't really understand this. And they are asking me, they want more questions or more information. And that initial 65 minutes, I had to dedicate another 15 minutes. I would go back, addend my note, put 80 minutes, and then I would just come back to the chart and input another 99418 to make it 2. Maybe I'll have to look at this and then I'll just do quantity. And I'll go up to 2 and then I will accept that. So now in these charges, I'll have a subsequent hospital visit, which is a 99233, up to 50 minutes. And then I'll have billed 2 of the prolonged services. But it's important that if I do bill this 80 minutes right here, and I can even go down here and just add, went back and spoke to the family. So that's how you're going to end up qualifying. The documentation will then match what you're billing, which is the main part of all this. I don't want you to just put in a bunch of subsequent visits because you spent a lot of time. You need to make sure that the documentation matches. And if you didn't spend 80 minutes with this patient doing all of this that's written in here, then don't bill these prolonged services. You want the bills that you're charging to match the documentation, and ideally, actually absolutely, for it to all be true. So that's prolonged services.